All right, guys. Assalamu alaikum. My name is Dr. Reem Sheikh. This will be the first of, inshallah, many series of case workups that we do. The goal of this is to generate discussion, a healthy discussion, where we can discuss various treatment approaches, case workups. How do we get from point A to point B? What complications can happen? How do we plan our surgical management, post-op care? And there's never a right or wrong answer, but my goal is to engage the audience, you guys, and present this to a variety of people in their career, so students versus residents versus seasoned attendings. So feel free to chime in. Let's have a healthy discussion. Okay, I really don't want to just listen to myself talking to myself. Okay, so let's start. So this is towards my students now. I'd expect you to answer some of these questions. All right, so HPI, you have a 65-year-old female with constant throbbing pain and stiffness to her right foot for the last 5 years. Sometimes there's swelling and stiffness to her foot, to her neck, to her back, and her wrists. She started to limit her activities due to the pain, so let's say that now this is becoming lifestyle altering or disabling. She's not able to keep up with her physical activities. She rates the pain as 8 out of 10. When you ask her to point, where the symptoms are, she points to the forefoot, so localized to the forefoot area. She wants to return back to her active lifestyle. She's tired of living in the pain, and she's coming to you for a surgical consultation. So right off the bat, I want to set, the precedence that this is going to be a surgical workup, not conservative management. So let's just assume that she's, exhausted years of conservative treatment. So what would you like to ask her next? And for my 4th-year student.
I would see if she has any blood work done to see if there's any electrolyte imbalance maybe.
Okay, so now this is a patient in your clinic. Imagine this is me, okay, in clinic. I'm 65 years old all of a sudden. So this is me. I'm telling you all these symptoms. So how do you proceed next in the clinical setting? What would you know? She's a completely new patient.
Any imaging, like x-rays or anything?
Okay, backtrack. You're on your thought process is good, but backtrack something before that.
Clinical
You want
exam.
a comprehensive, yep, but before your medical exam too, you want a comprehensive H&P, correct? So for that, you want to know her past medical history, her surgical history, her medications, her allergies, and then social history of any sort that could be relevant, right, to your treatment plan. So she knows that she's pre-diabetic and hypertensive, but nothing else other than, allergies to penicillin. Perhaps that would be a consideration to know for surgical treatment, right, with pre-op antibiotics and post-op antibiotics if need be, or to manage an infection. But her social history is positive for her being a smoker for the last 30 years. And she says it's been very consistent for half pack a day. So that would be something that I would be concerned about as an attending, because smoking, what happens when you smoke? What happens to your vessels when you're smoking? And anybody can answer this.
They constrict.
Correct. So vasoconstriction, right? And so when you think of your arteries to the toes, I usually tell the patients, literally, your arteries to the toes are the farthest away from your heart. So when you take a puff of smoke, right, you're causing that vasoconstriction, tightening of these little vessels, which are little pipes, supplying the arterial supply and stuff. So that's choking your blood supply. So for me, that's a big concern. And I do have a question I'll ask you following up with that. So this is basically her pertinent medical history that you would need to know. And then it's also important to know that, you ask her, so now your feet hurt. Are there any other joints, overall that hurt? Do your knees hurt? Does your hip hurt? Do your shoulders hurt? Do your wrists hurt, right? Does your neck hurt? Because when you're trying to work up, and then, clinically, obviously, you're going to take a look at the foot too. But, when you're trying to work up these cases, you want to be as comprehensive as possible. Okay, so now what would you do next, Aisha? You already told me the answer before.
Imaging,
So
x-rays?
no, so before imaging, you're going
blood
to
work?
examine her,
Blood work?
correct?
Yes.
No, you can examine her, right? So this is the patient, she's in front of you, okay? So here's a pro tip, or a Dr. Reem tip. Basically, whenever you're doing any cases, take pre-op and post-op weight-bearing photos and put them in the chart. And I picked this up from an older attending of mine who used to have Polaroid camera, and he would take a Polaroid picture of the patient pre-op and post-op, because patients also forget what their feet used to look like. And it's also just good to document. So always, take a pre and post-op photo. So anyway, here you go. This is her foot, okay, weight bearing, right? Now, tell me, how would you assess her clinically? And before you answer, I want you to kind of think of this systematically. So go distal to proximal, proximal, distal. What physical exams, right? What exams are you going to perform on her to assess what's going on?
So she's a new patient. You do VNOT, so you do vascular, neuro, musculoskeletal, all the good stuff, and then focus in on her specific symptoms. So she's saying it's a forefoot, so go through the digits and every joint, distal to proximal, and see where the pain is exactly.
Okay, so be a little bit more specific about the musculoskeletal exam that you do.
So you check her muscle strength in all muscle groups. So you'd have her kind of push against your hand. Just in terms of musculoskeletal, do you mean like within?
Tell me how you would evaluate her
contractures?
deformities. Tell me how you're going to evaluate her deformities, right? You could see she has global forefoot deformities, right?
So
And
you would do Coleckian push-ups on her digital deformities. So you see if they're reducible, they're
Okay.
semi-rigid, rigid.
Okay.
That'll kind of gear your surgical planning if you want to do something soft tissue versus osseous.
Okay, how are you going to evaluate the first stray? Because you clearly see she has a bunion deformity, right?
Yeah, that one you check if it's track bound or tracking.
Okay.
You check if the windlass mechanism is intact.
Okay.
Check the sesamoids. See if there's crepitus and range of motion.
Excellent. Okay. So when you're doing her first MPG range of motion, you assess the amount of range of motion, right? The quality of range of motion, like you said, crepitation. You see if there's pain during range of motion or at end range of motion, right? And if there's pain to the sesamoid complex. And then, of course, hypermobility. And then, say she has metatarsalgia. So like you said, you're doing the click and push up, then the Lockman's test to see if there's any dislocation or subluxation at the MTPJs for the lesser MPJs, correct? And then knowing if you have flexible versus rigid versus semi-rigid hammer toe deformities or claw toe deformities. Okay. And then, that's your distal examination. And then you could go, work your way proximally. So mid-tarsal range of motion, subtalar range of motion, ankle range of motion with your silver scoy test, right? I always assess these patients weight bearing and off weight bearing. Okay. So that's very important too. You mentioned, Fatima, tracking versus track bound. And because we have a fourth year student here who I assume you know this, but let's just quickly review. Can you tell me, we'll go back to that slide. Can you tell me the difference between tracking versus track bound? What does that tell you? Why do we do that? And what is it telling you? What's the clinical relevance of assessing the first MPJ that way?
Were you asking the fourth year or myself, sir?
Both of you. I mean, I'm sorry, there's not that many people here. I'm just trying to have a, discussion, but anybody can help. But what is that telling you, right? That's obviously you do that for a reason. So tracking versus track bound, like how is that going to help me make my clinical decision? But what information does that give me?
If it's a foot deformity or if it's not, like if it's osseous or if it's soft tissue like tendon.
Okay, so progression of deformity, okay, which is worse, tracking versus track bound. Do you know the difference between tracking versus track bound?
Track bound would be worse because you try to kind of hold it, correct it, and see if it's held. Versus track, but it'll kind of go back to
correct. Absolutely. So the way you want to assess for that is I usually put the foot in a neutral position. I reduce the IM angle, and then with my IM angle reduced, I will put my first MPJ through range of motion, right? And then if it stays reduced and goes, dorsiflexus, plantar flexus without deviating, then that tells me that it's tracking. But then if it stays deviated while being dorsiflexed, then that's track bound. This is, I'm so explaining for our 4th-year student here, okay? So that also helps me engage the severity of the deformity, right? If it's a tracking, I can perhaps in my head get away with a metatarsal osteotomy, a lateral release. If it's track bound, I'm going to need to be very aggressive with my lateral release, or perhaps I'm thinking fusion. Okay, let me look at what the joint looks like on my x-rays. But the clinical assessment, even prior to getting imaging studies, right? Of course, with experience, it helps, but you kind of already have an idea of where this is going to lead to. Okay, so this is why I make a big deal of that. And then when you're assessing first MPJ range of motion, when you say that there's pain, like Fatma, you mentioned that, you know, to assess if there's pain with, you know, during the range of motion or to the sesamoids, what is that telling me? Like in my head, why would I want to know this information?
It correlates with when you're looking at hallux rigidus versus limitus, and you're looking at like if it's far like into hallux rigidus and it's limited range of motion and they have pain, then there's also a rotational component to it that you'd have to address surgically.
Okay, and then also the main thing being, if there is pain, right, you can have a deformity and perhaps not have pain, okay? But if there is pain, then that to me is indicating the degeneration of the joint, right? So that there's advanced or there's arthritic changes within the joint. When there's pain, you know, along with crepitation and to the sesamoids, that there's already arthritis set in, okay? So in my head, if there's pain, I'm leaning more towards fusion, okay? If that makes any sense, all right? Also, when you're done with residency and you're applying for boards and stuff, if you know, when indicated, you want to document these specific findings in your chart to justify the procedure that you're doing, okay? So let me go back to that slide. So this is my physical exam. Obviously, she has moderate pain for hallux valgus, Taylor's bunion, a budding, hallux budding second digit, enlarged eminence, all that stuff. So main thing, first MPJ is track bound. The range of motion is less than 20 degrees dorsiflexion, 10 degrees plantar flexion. There's pain at end range of motion and to the sesamoids. And then there's, you know, metatarsalgia present with prominent met heads. You know, let's also clinically, I want you to paint the picture. I don't have a picture of the plantar foot, but clinically, I want you to think that there's fat pad atrophy and distal displacement of the fat pad, okay, which makes the metatarsal heads even more prominent, all right? And we see this more commonly in females because of perimenopausal changes, menopausal changes, hormonal changes, and then just generally speaking, you do get fat pad atrophy over time, okay? So I want you to have that picture in your head too. You have semi-rigid contractors of the lesser digits. The second MPJ is stable on Lockman's, dorsal subluxation. So, you know, the joint is decent, okay? All right, and then of course, goes without saying that you have wider forefoot to rear foot. Okay, so this is, we've established now where we clinically stand. Now, you said we needed imaging. Okay, quickly. Now, during your physical exam, right, you obviously are going to do a neurovascular exam too, right? So you palpate the pulses, correct? You're palpating the DP and the PT. And what additional thing would you want to do? Let's say if the pulses are weakly palpable, just for educational academic purposes, what can you do in clinic to better assess the circulation, right, or the vascular status, and what additional testing can you order?
Doppler and ABI.
Okay, so when you do a Doppler, okay, I will even Doppler digital arteries. When I have patients that come in, let's say, you know, they're diabetic, they don't have the healthy skin, atrophic skin changes, loss of pedal hair growth, but they, you know, perhaps let's say they have an infected ingrown, I'll go ahead and even Doppler digital arteries to kind of help me make my clinical decision right then and there. Okay, so don't be afraid to even Doppler digital arteries. And good vascular studies, ABI, PVRs, TBIs, if you want to go that extra step, if it's warranted. Absolutely get that pre-op. Absolutely. I do not negotiate on these things at all. What testing would you want to get in terms of lab, given her smoking history?
Arterials?
No, lab work. I'm not
Oh,
talking
lab work. So she takes folic acid, so I'd do like something vitamin D related.
Okay, excellent. She is 65 years old, right? So great assessing your vitamin D. Absolutely. And supplementing that pre-op, post-op, you know, I always supplement, I always check. And I think I do not compromise on. But one thing specifically with her smoking. What do you want to
Bone
check?
density, skin?
Nope.
No, that's more her age.
No, I want you to give me a lab.
You're thinking just more like nicotine?
Yep. So cotinine, my English is not the best. So those levels, right? Because now if I stress to her, listen, I need to fix your foot, but I can make it look all pretty, but you're going to have surgical complications that involve wound, delayed wound healing, bone healing, all that stuff. And I cannot be responsible or put myself, in this position to set you up for complications given your smoking history. So I will stress compliance, right? I will discuss smoking cessation. Then I will check the levels. And when they come back for their pre-op appointment and I need to recheck it, right? If they're not being compliant, I'll be like, listen, you haven't been compliant because the labs are telling me the facts, right? So I always do cotinine levels if they're an active smoker. Okay, so I don't compromise on pre-op vascular testing, and I do not compromise on checking cotinine levels or vitamin D levels. They are a part of my pre-op workup. Okay, all right, excellent. So imaging studies, Aisha, what would you get? You told me you needed x-rays, right? So what kind of x-rays would you get?
Are you talking about like what views?
Yeah, tell me what views.
AP, medial oblique, and lateral.
Okay, so good. I'm going to give you an AP and a lateral. Can you tell me what other, maybe Fatma can help you here, what other x-ray would you want to get to assess the first ray deformity?
Would it be sesamoidal axial?
Desmoid axial. Excellent, because it tells you the transverse plane of the deformity. Excellent, good job. So here's your x-rays. If you want to quickly describe them, I think it would be helpful because you're a fourth-year student. No need to be shy. Honestly, it's just a bunch of us discussing this. Tell me what you see, and let's just focus on the forefoot.
Okay, so this is like actually like one of my weak points. Okay.
It's okay. That's okay. I learned too. Don't worry.
Are you talking about like angles or just like?
No, I want you to describe. Let the angles be. But I want you to describe, what do you see? Can you see my cursor?
Yes.
Yeah. So I want you to describe what you see here. What do you see here? What do you see here? And then looking at the lateral, like what changes are you seeing to the joints? Like, how do you describe this? We already have established clinically. She has a bunion. She has hammer toes, claw toes, right? Metatarsalgia.
So hallux abductovalgus.
No, valgus, right?
Valgus,
So she
valgus.
has hallux valgus, right? She has hallux valgus deformity. Look at the quality of the joint. So she has a moderate hallux valgus deformity. You could see that there's joint space narrowing. You see that there's subchondral sclerosing. You see that there's mild subluxation of the first MPJ. You see that there's enlarged dorsal medial eminence. You see that the sesamoid position's right. Of course, your tibial sesamoid position, like 6 at this point. Now, just because this is an x-ray, that doesn't mean you can ignore the soft tissue. You could see that there's localized inflammation, right, to the dorsal medially here. You can see that there's inflammation in the bursa at the first MPJ. You look at lesser MPJs, mild subluxation here, but the joint spaces are okay, but she has a lot of pain. You could see that there's a hammer to deformity here. There's underlapping or overlapping of the hallux and the second, so they're abutting, okay? So just because this is an x-ray doesn't mean it cannot give you information about the soft tissue. You look at the lateral, you see joint space narrowing, dorsal exostosis, and then the hammer toe deformity, okay? So this is not so bad, right? And here's your sesamoid axial. And when you're looking at the sesamoid axial, right, you look at also the quality of the first metatarsal, the crista, but then look how the sesamoids have shifted, and look how arthritic the sesamoids are in their articulation with the first metatarsal head also. So there's arthritis present to the sesamoid complex also, okay, in addition to the first MPJ. So you have global arthritis, osteoarthritic changes in the joint overall altogether, okay? So knowing what you know, okay, I'm just going to quickly go over this quickly. So labs, right? So now you have these x-rays and you have the clinical symptoms and you know her review system is positive for joint pain to multiple joints and stuff. You should be thinking in your head that I need to rule out some sort of an inflammatory response is going on, arthritis is going on. I need to do a rheumatoid panel or an arthritis workup, okay? So you guys are great in today's generation, Epic, you could type in arthritis workup or joint pain workup or whatever, it spits out all the labs. But back in my day, which was not that long ago, you had to order these individually. So need to know what to order, especially for boards, right? So your rheumatoid factor, anti-CCP, which is not specific but sensitive to an autoimmune disease, and a rheumatoid arthritis more specifically, your ANA, that will help you diagnose if it's rheumatoid versus psoriatic, your ESR, your CRP, okay? And we've already talked about the vitamin D and the cotinine, but more so to the pathologist as patient, you want to do a rheumatoid workup. So these are my labs, and they're positive for rheumatoid factor. You see that her inflammatory markers are up and also the anti-CCP. So leads me to the diagnoses, given my clinical findings, my ESR findings, my lab findings, that it's rheumatoid arthritis, okay? So now that we've established that, I'm glad I put this in mainly for the students. So I want you to think when we're talking about surgical planning, I want you to think exactly what rheumatoid is about, right? So rheumatoid arthritis is an autoimmune inflammatory, it's an aggressive and progressive disease, osteoarthritic disease, okay? You must appreciate, the extensive destruction that happens with the synovial inflammation that leads to basically the degeneration of the joint. So it's the pannus, the formation, and then the ligamentous laxity and the instability that happens, then the changes within the joint, okay? So I want you to keep that in mind, the progression of the disease, regardless of the stage we're in, knowing that information, how do you then surgically plan? Yeah, Fatma, I'm getting there. So then how, with knowing the progression and the aggressiveness of rheumatoid arthritis or psoriatic arthritis, let's say autoimmune inflammatory osteoarthritic diseases, how do you then surgically manage these patients? So this is looking at a radiograph. You could see that perhaps the first MPJ is not as terribly affected in terms of hallux valgus deformity. I don't have a lateral, and this is off of a journal article, but you could really start to see like the progression, the changes of, the lesser MTPJs, and then also the IPJs of the disease progression of that chronic synovial inflammation and how that destabilizes the forefoot. So what medications would you consider? For the sake of time, I'm just going to go. You obviously, will do a rheumatology rotation and stuff, should learn this, but also for board's perspective, right? So what medications should be considered? You have your corticosteroids, your DMARDs. Now, when I have this patient, she was not aware of her past medical history being significant for rheumatoid, right? So I will refer her to a rheumatologist to get on the medication to have the disease properly managed, in addition to my surgical intervention. I'm not just going to treat her and then refer her to a rheumatologist secondary. I will do this as part of my pre-op clearance, get pre-op clearance from a rheumatologist. Now, it's important to recognize these two classes of drugs, perhaps, for preoperative and anesthesia planning, right? And why do I say so? So if the patient is on methotrexate, right, what is happening per anesthesia rex or PCP rex or rheumatology rex? How does that play a part in being held pre-op? Do you give it to them the same day of surgery? Do you hold it 24 hours before, 48 hours before? Does it make a difference? Does not make a difference? What do we do? So you hold it, right? Usually 24 hours pre-op, it's being held. So held usually the day before surgery. And steroids, right? What can happen when the body is stressed out, perhaps during surgery or so, because these patients may be not specifically our patient for the, but for the sake of discussion, steroid dosage may need adjustment in that you may need to increase the dose because of adrenal suppression, right? Because of the stress from surgery. So you definitely don't want the patients crashing, okay? So important to note, you can obviously research this, but I put this in here just to be more comprehensive, that, these medications, sorry, I misspelled medications. Medications can have adverse effects, and it particularly plays a role when we talk about anesthesia. Yeah, go ahead, Jeanette.
Yeah, I had a question. So, have you had a patient that has rheumatoid arthritis that it's on Enbrel, etanercept? I think that's how you say it. Because like I had a situation where the PCP was like, you should hold it for like a week before surgery, and then the rheumatologist was just like, go ahead and continue it. So, and at the end of the day, they're just like, this is disagreement, surgeon preference, do what you want. And it seemed like in that situation, it was kind of a pros and cons of like, okay, if you continue the Enbrel, there's a higher chance of obviously immunosuppression, infection, things like that. Whereas if you stop it, then the patient's probably going to have more postoperative pain, which is what the rheumatologist told me. So I just continued it. I didn't have any issues.
Yeah.
I just thought it was an interesting disagreement between the PCP and the rheumatologist. So what would you do in a situation like that?
Yeah, I think I would have kept it going too, but I also would have called my anesthesia colleagues and said, is there any issues with this, with anesthesia interaction? Am I worried about any sort of toxicity related to this when the patient undergoes anesthesia? So, and if the answer would have been no, then I would have done the same thing you did. I would have continued it and not worried about it, because post-op pain is also, and we can go into a big discussion with that, because these patients are complex patients. Not only are you worried about post-op pain, you're also worried about, obviously the integrity of their soft tissue, their overall health. Now, if they have rheumatoid arthritis, you're fixing one foot. Do they have enough help, to be completely off of it? How are you going to do your post-op rehab? Are you going to put them in a cam boot? You obviously, if you're doing something more aggressive than forefoot, more like rear foot recon, are they going to tolerate being non-weight bearing? All that stuff. So these are complex patients, and these little decisions affect their overall well-being, which, if they're in more pain, something else is hurting, they're not able to tolerate the non-weight bearing or protective weight bearing, it's all going to come down to the surgical outcomes, right? Increase your complications, God forbid, one way or another, right? So thanks for bringing that up. I would have continued it too. Yeah, and patients, when they have pain and stuff, and when you do these procedures and they have wires sticking out, like pain makes people do crazy things. So it's hard to predict, right, what they can do. They pull their pins out, all those things.
Like sometimes I'd rather deal with delayed wound closure than increased postoperative pain, depending on the patient. So
yeah, agreed. And then I also, if it's too delayed, and if I do big reconstructive procedures, I always do pop blocks. And so postoperative blocks, this is mainly for our resident and student here. Postoperative blocks, preoperative blocks, they go a long way when it comes to pain management. I'll also supplement sometimes with gabapentin, 100 milligrams, at bedtime, or once a day, to kind of do that too, to help manage pain. Now, if I'm worried about the patient developing, chronic regional pain syndrome or something, vitamin C is also a good way to go. So lots of research, again, another discussion that we could completely have on pain management when it comes to these patients. And if, there's a depression history, there's some sort of a psych history, there's some sort of a social, that can predispose them, right, to having worse pain and those related outcomes. So good point. Okay, yeah, so need for medical clearance, right? On this patient, I would do that, get medical clearance and rheumatology clearance. So who brought that up? Fatima, I think you brought up, right? Getting C-spine CT, you had said, or x-rays. So for our student, you must get C-spine x-rays, okay? And so why would you get that? Because of anesthesia. So you can have, atlantoaxial subluxation, right? So that can be can have very serious consequences if not, I guess if not established that the patient has that already, because it can risk severe spinal nerve injury and also vertebral artery compression that can, you don't want to go there. So a lot of complications that can happen just from something that simple. Okay, so knowing what type of atlantoaxial subluxation there is, because if it's anterior, it's worsened by neck flexion, which is the most common kind. If it's posterior, then by neck extension. And so you think of the patient undergoing anesthesia and how they're manipulating the neck, okay, while they're doing that. So that is why that is important to know. Okay. Okay. So enough of that stuff. Now let's go back to feet. Let's talk about a surgical plan. Tell me what you would do, what you wouldn't do. Your goal, this patient is saying, I want to go back to being active. I used to run, 5 miles, whatever, every day or 3 times a week or something. I want to get back on my feet, doc. Help me get back feeling normal, pain-free, or in less pain. Tell me how you can help me. So let's come up with a surgical plan of how you'd approach this. Again, there's no right or wrong answer. Tell me what you think you would do, and I'll tell you what I did.
So for the first MPJ, since there's hallux rigidus, I would do a fusion.
Okay.
And then for the lesser digits, since they're semi-rigid, I would do arthroplasties.
Okay. Remember that she also had metatarsalgia. So perhaps our attendings here, this is a patient coming in. What would your surgical plan be for her?
Like a while? Is that what you meant?
Okay. So you are saying you would do first MPJ arthrodesis. You would do while for 2, 3, 4?
Uh, I mean, I would. Yeah, I guess you can do that. Yeah.
Okay.
Or what's that called when you there's like a procedure, it's like when you do all the metatarsals for rheumatoid, it's called I forgot what starts with the letter.
Okay. Okay. Maybe
I
I
don't
should.
remember what it's called.
Okay. Maybe I should know.
I'm sorry, can you repeat that?
What would your surgical plan be for a patient like this? So you know she has crepitation and pain to the first MPJ. It's very arthritic. You know she has pain submit 2 through 5. You know she has a Taylor's bunion deformity, and you know you have the claw toe deformities.
Wow. Would Lapidus be wrong for the first met or no? Or for the first tray or no?
Okay, so let me ask you this. What would help me decide clinically that I could do, which would be therapeutic and diagnostic at the same time? If I'm torn between doing a first MPG fusion versus Lapidus, what can I do in clinic to help me decide which is the go?
It says hypermobility.
Tell me something that I could that's invasive, that's therapeutic and at the same time diagnostic.
A steroid injection?
Close, not a steroid, but a local block, right? So it just blocking the joint with lidocaine. Okay, and I usually do this for my rear foot joints. I have never done this for first MPJ, but okay, since we're here discussing this, so let's say I'm like, oh my goodness, I don't know. Okay, I'm using my hands too much. My phone, my computer's like, stop using your hands. So you know, deciding between Lapidus versus first MPJ, if I do a diagnostic block, okay, and I inject the first MPJ, the pain is 100% gone. I know that's the joint. Let's say I start with doing the first metatarsal joint. I inject that, which, okay, let's just say for the sake of discussion, I inject that first. And the patient's like, no, I still have pain. Then I inject the first, you know, she's like, I have 0% pain relief with that. Then I inject the first MPJ and I have 100% pain relief. So that will help me also clinically. And I do this for my rear foot fusions, right? If the patient's coming in with rear foot pathology and it's between subtalar, you know, CCJ or TNJ, and then I go about injecting the joints to decide which ones I want to fuse. But anyway, so you could perhaps do that. But you know, clinically she has pain, and you know, and it's a very arthritic joint with severely limited range of motion. So I'd go for first MPJ arthrodesis. It will help me reduce the deformity, and it will help me address the arthritis that's within that joint. So Lapidus I would not do for this, because the first MPJ is already so degenerated.
I have something to add as well. So you
Yeah.
just have to go back and think about the pathogenesis of rheumatoid arthritis as well. You're having inflamed synovium, right? So doing a Lapidus or fixing the osseous deformity back there, even though it may clinically get you a good X-ray and think you may do a good job with that, it's not going to fix the pathogenesis of the condition. So you're still going to have inflamed synovium. You're still going to have joint degeneration at the first MPJ where her symptoms are at. So you really have to go by your clinical examination and understand the pathogenesis behind the pathology that we're treating.
So I would apply that to my first and my lesser MPJs when I'm thinking of my surgical planning, right? So I'll tell you what I chose to do, and we can go into discussion because I have other examples of what things you could do. What I chose to do, and Fatma, you were probably thinking the Clayton-Hoffman procedure, which is a classic textbook name for first MPJ arthrodesis, lesser methead or pan methead resection all across through 2 through 5, and then arthrodesis of the PIPJs and DIPJs if needed for the digits except the 5th. Okay, so that is what I chose to do. So instead of asking you, okay, shoot, hold on, I'm gonna skip this for a second. Okay, so that is what I chose to do. Here is my post-op x-ray. Now, I'm a person who's a creature of habit. I know what works well in my hands. I do not care about reps influencing my decision on what hardware to use. I go for the most basic that can accomplish the most, and is the cheapest, perhaps. Okay, so I stay simple, stupid, textbook perfect is my goal. Okay, so my approach, I did a first MPJ fusion here, which you could see that clinically, you know, of course, this is a non-weight bearing x-ray, but this is my immediate post-op x-ray. You could see that it's reduced. I basically took out the joint cartilage, whatever, denuded the joint, put it together, and I used to fix it with 2 crossing screws. For the med heads, I did a pan med head resection, but if you pay close attention to the metatarsals, I was not very aggressive in resecting the metatarsal heads. I literally resect at the flare. I don't go to the surgical neck. And then I attempted to arthrodesis 2 through 4. And 5th, I just did a arthroplasty of the 5th digit. Okay. And I chose to pin the 5th too. All right. So this is what I did for this patient. Now, why would I choose first MPJ arthrodesis, right? Not only is it gold standard, but as we've discussed already, the progression of the disease and having that in the back of my mind. However, let's say you have a patient that says, hey, I don't want that. Even though they, let's say they have more range of motion. Let's say their joint is not super arthritic, and they're younger. Okay, this was a 65-year-old. Let's say this patient, somebody who's as old as me, in their late 30s or early 40s, even early 50s. So, think of this, and I'm going to come back to this, but think of this thought too. Okay, so gold standard for progressive rheumatoid arthritis, for moderate to severe disease, of the first MPJ arthrodesis. Lots of literature on this. I put this article in here because, believe it or not, for the student and the resident, believe it or not, when rheumatoid arthritis is involved, given the inflammation and the turnover with the osteoclast and osteoblast, you have a better fusion rate in comparison to just general osteoarthritic changes to the joint. So people with rheumatoid fuse beautifully. They fuse better. You have excellent clinical outcomes. You have predictable results. Your gait significantly improves because now you've stabilized the first MPJ. So there could be an argument that if you do a metatarsal head resection of the lesser MPJs, pan-med head resection, you're destabilizing the lesser MPJs. That being said, when you stabilize the first MPJ, you correct the deforming forces, the disease is going to progress, then the pan-med head resection will actually be okay because you've stabilized the first ray. So this is why first MPJ arthrodesis, very good, excellent predictive outcomes, really good results. All right. This is why you want to do that. For my student resident, what are the principles of arthrodesis?
So it's Gissane's
Yeah.
principles. So you remove, sorry, my daughter's being.
It's okay.
So you remove anything that would impede bony contact. You would have it in appropriate position. This is like an interview question.
No,
I memorized.
I gave you the answers. So you have the
okay.
principles. I gave you the answers, and I'm not pimping you. I'm just asking you for, just to be comprehensive in our review. So, denuding or removing all of the cartilage and the fibrous tissue, right, to subchondral bleeding bone, prepping the joint is key to achieving good fusion. You need to have an accurate and close fit, together, the approximation of the joint surfaces. You need to have optimal positioning after it's fused, how it's going to function. And then you need to maintain that. Some people will say, oh, compression across. No, the answer is not compression. The answer is having some sort of fixation or whatever it may be to maintain that opposition so that it allows for, the fragments to heal and have a fusion. Okay, so this is my final post-op X-ray for her. You can see there's first MPJ arthrodesis. I got a pseudoarthrosis at the second PIPJ. The third looks like it fused. The fourth got a pseudoarthrosis, and 5th was an arthroplasty. But you could see that I got reduction of that. And again, like not super aggressive of my pan-med head resection for the lesser MPJs. Okay, so I'm going to go back now. Now we talked about like all the, great stuff that we can do. Now, as much as you want to plan your osseous correction, you have to also plan your incisions, right? You cannot just be neglectful or, just be very careless about when it comes to incision, especially in patients that have pathology like rheumatoid or, some sort of a dermatological component that may, be present too. And she's a smoker, right? So I'm definitely worried about the skin integrity. I'm worried about wound dehiscence, which will not be good because it can lead to infections and all that good stuff. So I'm definitely worried about the quality of your skin too and post-op healing. So tell me, how would you make your incisions? You already know what procedures I did. So now tell me, how would you address this, your incision planning?
I kind of just do in the interdigital spaces for the pan-mat head. So
start medial. Start
medially
with the
for the bunion. We do the typical dorsomedial incision. And then for the second and third, I would do something in between the two to address the two, kind of like when you do for neuromas.
Okay. This is in
And
the inner space.
yeah.
Okay.
And then for 4 and 5, I would do one over that inner space.
So you're saying you'd go here, dorsal medial here, you'd go in the second inner space, and you'd
Yep.
go here in the fourth inner space. Okay.
Yes.
That's your planning for the first MPJ and pan method. What are you going to do with the toes?
You mean positioning?
No, how are you going to address, if you make an incision here to here, you cannot address your hammer toe deformity, right?
Oh,
Not
yeah.
at the IPJs and P, right? So how would you do that?
Oh,
I know I
you
got
can
you.
do, I was gonna say you could do, so for hammer toes, you could do linear or ellipsoidal.
Okay, so you're saying do 2 semi-ellipticals over the IPJs for whichever one I want to address, right? And then
Yep.
do that. Okay, so you're gonna have 1, 2, 3, 4, 5, 6, 7, 8, 9 incisions. Okay.
A lot.
Well, okay, it's gonna take you forever to close, but okay. What other approaches would you do?
I mean, you could just go linear over each metatarsal. That way, I mean,
So-
each ray.
Each ray. Okay,
Yeah.
so now when you tell me you're gonna do that, what's the most appropriate surgical approach to go over lesser MTPJs? So you're gonna start linear here. Okay, I agree with that. When you come here and you're approaching this zone, is there something you'd want to do, or just go linear?
I mean, you can cheat it a little bit lateral just to get that other digit. Is that what you mean?
Mm-mm.
Oh, okay.
How would you go over the lesser MPJ? How would you go over the MPJ area?
Mhm.
Keep it straight. Do a lazy S. Do a lazy S.
Lazy
Okay.
S.
Why would you do a lazy S? Because think of healing. When this heals, if you do a linear, it's going to contract. Okay. And the soft tissue, like I said, you have to pay attention to the soft tissue as well. And so when it contracts, right, that's going to hinder your outcomes, right? So basically your correction of this. So you could go linear, lazy S over the MPJ. Okay. So now you've decided, and Fatima, you specifically again, now you've decided you're going to do a dorsal medial and you're going to make 5 or 4 other incisions, right? So knowing what we know about her social history, about her integrity of the skin and stuff, how far apart are you worried about wound dehiscence when you're telling me now you're going to do 5 incisions? So
You're
ideally,
still worried about it, yeah, because she's
okay,
a
so
smoker.
ideally, how would you plan it out so that you don't get into trouble?
With the, you mean with the skin lines? Like
With the 5, no, with the 5 incisions. So ideally, you'd want to be
Okay.
about a centimeter apart between.
Oh, okay, gotcha.
Okay, because you're going to have skin necrosis if they're too close together. Okay.
Gotcha. Yep.
All right. So excellent. So I'm just going to quickly review this. So incision planning, dorsal approach versus the historic or the sometimes applicable plantar transfers approach, right? So again, depends on the deformity. What are you trying to accomplish? The integrity of the skin. You can have 5 versus 3. These are examples from the internet. These are not mine. So 5 incisions spaced approximately a center apart. I did do 5 incisions for this patient. I'll show you the post-op picture, but you have to be, again, careful that they're not too close together because they will necrose and they will dehiss. And then lazy S or serpentine when you're addressing specifically across the MPJ or over the MPJ. This is an old picture from the PI Institute, and you see they just made linear incisions. So we do not do that anymore. Okay. This is your classic transverse all across dorsal or transverse all across plantar approach, which is the Clayton-Hoffman versions of it. And so we do not do that anymore. However, if you have patient that has significant rheumatoid nodules that need to also be addressed at the same time, this is an excellent approach. Understand though that you will have to make a different incision to approach the first MPJ dorsally to prep and fixate that, and then also for the IPJs of the toes. Okay, so you're going to have to use a combination of dorsal and plantar incisions for that. But historically speaking, and if indicated, perhaps they are there. Okay, all right, excellent. Just to quickly, for sake of time, really first MPJ arthrodesis. Like I said, the main focus when you're doing to have a successful result and bony fusion is maintaining that biomechanical structure of the joint. So cup and cone, the technique, or basically, the concave and the convex surface of the joint, maintaining that integrity is key. Also, the positioning of the joint is key. Okay. Method of fixation, you could use your 2 crossing screws. You could use a screw with a plate, whatever works for you. I tend to do 2 crossing screws as my go-to. And if I'm not able to do that, then I throw in a plate. But maintaining that contour of the joint is key to having good fusion, joint prep. You can see in this picture, G, that they've fenestrated the joint. So I do that too with my K-wires. Sometimes I'll put in, augment it with something. If the patient, I'm not too confident that they're going to heal well, then I'll put in some sort of, BMA or extra stuff to help it heal. Okay, so we did this already. This, yeah, go ahead, Mitsu.
Yeah, I had a quick question about incisional approach. What are your thoughts on just doing those 2 interspace incisions between the second and the fourth, and then doing like transverse elliptical incisions for the PIPJs to address the hammer toes?
Yeah, I think it's fine. I
Instead
think
of
it's
just
fine.
doing a lazy
Instead of
edge
this,
incision,
the
like
long railroad
linear
tracks.
all the way down to.
Yeah, no, I think it's fine. You could totally do 2 semi elliptical, at the joints. And that also helps because sometimes, because it's so chronic, not so much in this patient, but because, you get that callus on top because it's been such a chronic deformity that's really hard. You're not going to address that when you do a linear transfer. So doing the 2 semi elliptical is an excellent way to do it.
Yeah.
Perfectly fine. Absolutely. And then you could do your incisions, second interspace. Absolutely. There's no harm, no foul. Absolutely. So I've done both. But in this case, I chose to do it this way. Yeah, no. And then, this is an African-American patient too. So also if the patient is prone to keloid or hypertrophic scarring, that's also important to know. Absolutely. So no, there's no right or wrong answers, right? It's whatever you can do. But if you do the 5 incisions, knowing that you have to space them out because you're going to get the necrosis. So
in residency, I was in a case, it's not textbook, but we just did 3 incisions, like 1 over the dorsal medial first MPJ, 1 over the second interspace, 1 over the fourth interspace, and then we basically did like osteoclasis of the digits. Basically broke the toe at the PIPJ level to get it straight, and then just ran wires down it.
Yeah, and then MIS is also, that's another thing too. So people just make like very small incisions to prep the joint for that. Yeah, absolutely. I think it's just whatever, per case, your experience, your expert, like whatever you choose to do. There's so many ways to address this completely. So, and now there's like the, whole talk of MIS for MPJ arthrodesis too. So whatever you choose to do, whatever you're comfortable and will have good results in your hands. So good point. Okay, I'm going to throw this for my student and my resident. You're so happy. You're like, man, I'm going to call whoever and tell my best friend, I did this entire 4-foot slam. My case went amazing. Oh my God, I rocked. My attending was so happy. My goodness, it was perfect. But then while you're having this conversation, the PACU nurse calls you and she goes, Doc, the toe won't pink up. I'm ready to send the patient home, but I have a blue toe. So what's going on? Why do you have that blue toe? And what are you going to tell this person over the phone before you make it back to the hospital? What sucks, but yeah.
So you would have them, so blue toe versus white toe. White toe is like arterial versus blue toe. So
Okay.
they can kind of, well, I don't know if they can do it, but kind of move the K-wire around.
So would that be the first thing you do?
No, I think the first thing would be loosen the bandage or take them out of elevation.
I would take it out of elevation. Excellent. I would say put the leg in a dependent position.
Yeah, dependent position, and then check it. And if it doesn't pink up in like 10 minutes, then maybe you can get them to move the K-wire, or you come in and do the K-wire, I guess, because I wouldn't trust anybody else to mess with your fixation.
Yeah, okay. So, excellent. Blue toe or white toe. Now, before you leave the operating room, and this is perhaps for my colleagues that are out in practice, what can you do for your satisfaction and making sure that you have good cap refill? Because obviously, this is a contracted deformity. You can have the vasospasm, the arteriospasm. You're very prone to getting that blue toe or white toe. So how can you, leave with a peace of mind that your cap refill is intact? Like, what would you do in the OR? to ensure that it's okay.
Do you mean giving like a lidocaine block to vasodilate it?
No,
Slowly?
so I'm more so leaning towards like your time in the OR. So I
Don't you
deflate.
Don't you put like that DVT prophylaxis thing on their leg to prevent?
That's the opposite side. That's the
Mhm.
non-operative limb,
Yeah.
not the operative limb. You're
Okay.
talking about you're talking about the Venodyne boots, right?
Would
Yes.
you like keep the toes out? Is that what you mean? Like when you're dressing them?
No, I deflate the tourniquet and
Just
I
like
close it
turn
wet.
the closure, right?
Yeah, I close it
Yeah.
wet. I make sure because it has happened to me. I had a diabetic patient who I did a forefoot slam on, not rheumatoid, but severe progressive deformity, needed global forefoot reconstruction. I did my ABIs, I did everything. I got the TBIs. Like I'm, like I said, a stickler about this pre-op protocol that I have. I did a while. I did an arthroplasty and I did a flexor tendon transfer, the girdle stone, and the toe would not pink up. So I took out my wire. I undid the flexor tendon transfer. Actually, I took out my wire from the met head. Only distally advanced it to just have it in the toe, not through the MPJ. And then I just bandaged it so in plantar flexion. So this will happen. It has happened. And so my easy way of making sure that things go right before I leave is to deflate the tourniquet and close wet. Okay. And then some will argue, yes, but you're increasing your chances of post-op edema and all that stuff. But listen, be good with your suturing and get it done. So, all right.
How long
Okay.
did you wait before you pulled the pin? Like how long were you in the back area or
Oh,
the,
I think
OR?
that was the last thing I did. That's the last thing I did is I just retracted my pin because I always pin across the MPJ. So I retracted just to the digit. That's the last thing I did because I undid my flexor tendon. I did too much. What I should have done was a med head resection to give me more room to help the digit relax a little bit instead of a while. I should have been more aggressive with that. But, I bandaged it with betadine. The patient did fine. I kept the pin in for 4 weeks. I bandaged it with the betadine, splinted it for 6 weeks, and then I put him in a while splint with the MPJ and plantar flexion for another 6 to 8 weeks, and it ended up fine. But I share that because I was a new attending back then, and it was just like, wait, where's my cap refill? I need my cap refill. So going through the steps intra-op of undoing some of the things that I'd done because it was too aggressive. So that can happen. What I have. So this was this one case specifically. And just to show you diversity of how I do manage things, here's another one. A younger male, but again, knowing the progression, so you present the options to your patients. Listen, I could do a joint conservative procedure, but not when the first MPJ is this bad though. Let's say it's like a mild to moderate deformity, but the range of motion is still good. There's no crepitation. You don't see those osteoarthritic changes within the first MPJ, and you attempt a salvage procedure. More so for my students, I would like you to look up literature, on your own time, of why do we fuse it versus doing a joint sparing procedure, such as an Austin Aiken or a scarf when it comes to rheumatoid recons. And you'll see that the literature will tell you that there's a higher chance of recurrence, right? Because of the progression of the disease. Because the disease will attack the joint, weaken the joint, right? That synovial inflammation is going to continue to weaken the joint, the ligaments, the structure. So eventually you will lead to having that progressive arthritis. So you can have that discussion with the patient, say, listen, I could do a joint salvage procedure, but down the road, you may be looking at another procedure because of the advancement of the disease, okay? So this is another example. This one I chose to do a screw and a plate, okay, and did my classic lesser med head, pan med head resection with the arthrodesis of the lesser digits. Again, I'm not too aggressive when I do my pan med head resection because I don't want a floating toe or to completely destabilize the lesser MPJs. This was the final post-op. You get some sort of like a pseudo-arthrosis or a complete fusion. Either is fine. You've reduced it. You've stabilized the first MPJ, and so you've really taken care of the long-term outcomes of how the patients do. This is from the internet. I do not do this for my rheumatoid. I stick to textbook, So I put this in here. Like, is this halal, right? So here you go. You have a patient that has, yeah, I thought it was funny too. So here you go. You have progressive, rheumatoid. You could see that the first MPJ, completely arthritic, sublux. You could see the valgus is in the hallux is in a valgus rotation. Like I was telling you earlier, Aisha, X's will tell you a lot about the soft tissue. So you can see that the hallux is rotated to a valgus position. There's overlapping of the 2, 3, 4 digits. You can see that there's like subluxation of the second MPJ, right? So this one they chose to do, and this was from an ortho's website, by the way. No, this is a what do you call them? Well, foot and ankle ortho people, not podiatrists. So they did some sort of an osteotomy combo with Weil and an Aiken. Okay, so I would not do this. All right, and they were like, "Look, we do forefoot reconstructions, and so great. Do not do this, okay? Especially if it's progressed to this point." All right, so now I have another thing to throw towards you before we go. Here's a patient. Let's assume actually, I had this patient in clinic yesterday, 81-year-old female, does not want anything aggressive. She's bothered by the second toe. It rubs on her shoes. She's really concerned. It's the callus is getting worse. She cannot wear those heels to church. She doesn't want an aggressive procedure. She is very osteopenic, osteoporosis. Skin doesn't look great. You know, you got the thin atrophic skin like you could see in the photos here, no pedal hair growth. What do you offer her? But she wants you to help her with that second toe.
I had this exact scenario on my foot, multiple choice of ABFES.
Oh, yeah.
So,
Yeah.
yeah, so it does show up. Hopefully one of the residents or students can answer this.
Yeah. I want you to think about this. What do you offer her? At the risk of getting
Floating?
kicked. What's that?
A floating osteotomy on the second? Is that what you meant?
So do you think if you address just the second, it's going to help? We've already established, right, that the problem, it's like a global forefoot deformity, right? So the first MPJ is really the problem, right? The bunion is really the problem here, correct? It's that toe that's pushing in. And then that's why you're getting that dislocation at the second MPJ. And then you have that chronic claw toe, right? So really it's the hallux that's the problem. But she doesn't want you to touch the hallux. But you've got this like dorsally dislocated second digit that's just like right there staring you in the face. What can you offer this patient? Not
Might
a
be
trick
way
question.
too aggressive, but
No, go-
amputation.
Yes, a second digit amputation. Yep, and I have done it. Yep. And I had this exact same conversation with this lady yesterday. I said, "You're not a candidate for forefoot reconstruction because of all these reasons. What I could offer you, you know, at the risk of her like either punching me or kicking me in the face, is second toe could be gone. So second digit amputation. Because why? You're healing. Oh, what are you healing from that? Just the soft tissue, your incision, right? Your sutures come out 2 to 3 weeks. That's it. You're done. So second digit amputation. So don't be afraid to offer that if it's indicated. Of course, I'm not saying do that for all your patients, but if it's indicated, very well so, rewarding procedure also, and it's not wrong to do it. Okay, I think I'm talked out. Any questions, thoughts, you know, if you guys want to talk about complications that can happen or anything else that you've seen that you thought was, you know, could have done anything that was done here that you think could have been done better. For my case specifically, this was not mine, so I will not take credit for this. But
Yeah, I just want to talk about the first time I did one of these cases. Like, I know you pull up the PI image and said, like, we don't do this anymore. So
yeah,
fortunately and unfortunately, you know, the PI folks, they're very like, this is tried and tested, you know, I'm not changing how I like divert from this.
right,
Like,
right.
so at my fellowship, a lot of the people that I trained under or PI people, and they just said, just make straight linear incisions all the way down. You'll be fine. Just make sure you're over 1 centimeter from each incision. I
Uh-huh.
swear I did that, and it's still no cross. So
Yeah,
so I'm like, and
yeah.
I did talk to Rafa about it before the case, and he's like, just go medial, your dorsal medial, and then go between the second and the third and your fourth interspace, you'll be fine. But I'm
Mhm,
like, I just want to do the easier exposure at this point, you know, and like,
mhm,
surely enough, it came back to bite me. So yeah,
mhm.
lesson learned.
You learn with experience. I'm telling you that that one time I had that white toe, that one time, you know, and I was a new attending that one time. It took me longer to fix that problem than to do the entire forefoot slam because I was like, how do I fix this? The toe's not pinking up. So yes, experience is great, right? And anybody that says that they don't have complications is, I won't use any words here, trying to be as halal as I can be, but you know, they're full of it because if you don't do enough if you don't have complications, right? And so you are going to have complications, and that's how you live and learn. I have had some crazy complications, I'll tell you. I did a forefoot slam on one side, perfect. I did it on the other side. I did not change a thing. Okay, I'm a creature of habit. I do the same thing. I stick to the basics. Okay, I had a first MPJ wound dehiscence, ended up with pseudomonas, had to go to the OR. Alhamdulillah, didn't get into first, into the bone. I didn't have to do removal hardware, didn't get into osteo. But man, I did the exact same thing. I don't know how on the other side I had the pseudomonas dehiscence. And they picked that case for boards because I took that patient to the OR multiple times, plus it was bilateral. They know exactly how to pick these cases. So man, I lost a lot of sleep. I did a flat foot recon, one side on a 13-year-old, perfect. The other side, or he was 9 then, perfect. The other side I did when he was 12 or 13. I had a heel D-cube on a pediatric patient with a flat foot recon. There's nothing on it. Nobody ever has heel D-cubes on pediatric patients. Like, how do peds patients get that, right? Well, I get to learn his parents recently got divorced, aunt ran away, dad had another baby, the kid was living with a grandparent. I mean, there's a lot of social things going on, and the kid was depressed, didn't want to be off the splint, so literally sat there, played video games for 10 hours a day with the heel, and the posterior splint and the heel, wouldn't wear a cam boot. I mean, that was a nightmare. Okay, so things happen, complications happen, you learn from it, and you just, you can't say never. So alhamdulillah, it's all learning experience. You just gain more hair in the process. But yeah, things happen, you learn. So
What's a heel cube?
Necrosis of the tissue on the heel from pressure. So pressure ulcer. And that usually happens in your patients that are, diabetics on dialysis with CKD, or, so the poor vascularity is the reason you'd have a pressure ulcer. You would not have that on a kid. And I'm crazy about how I splint my patients. I offload the heel completely. I mean, this was just a one in a never occurrence that happened. So yeah, you learn.
I had a question about so with these forefoot recons, have you ever gotten a patient that was like a revision and you had to go back in and fix, kind of like, so going back to that is this halal picture, say that patient presented to you and they wanted to revise it, what would you do, like a hardware removal? And
I would fuse the MPJ. I would do lesser metatarsection, but I would tell them, listen, like, these are not virgin joints anymore. You have scarring in there. Of course, you never guarantee anything, right? So a part of my pre-op talk is always like, listen, I don't predict the future. I'm not God. I do the best I can, but there can always be complications. So in a revisional case specifically, I would tell them, listen, you're already prone to having, complications such as delayed wound healing, a lot more scarring, more inflammation, more edema, because somebody's already gone in and done stuff. And I don't know what was done, right? So, because when you go in, you're cauterizing vessels, right? Which is obviously going to play a part in post-op edema and stuff, right? So that's already been done. So I would remove the hardware, do an aggressive pen head resection, fuse the NPJ, put in some, bone matrix, put in some of that extra stuff that they sell, that the reps always try to sell you, like the BM, the bone matrix and all that stuff. So I would do that, maybe PRP in addition, vitamin D, keep them. I always keep my patients in a cam boot until I take their pins out, because the area I practice, non-compliance is a given. So, I will do things like that, but I educate the patient. Like, I cannot guarantee anything. So we will do the best we can, and this is how it's going to be. Sometimes no matter how hard you try, you really can't make it, any better.
is there anything that you do intraoperatively, like with that pediatric patient that got the pressure ulcer? Do you kind of offload more at the heel? Do you
I always offload my splints. I make them to where I literally offload the heel so that there's nothing that's touching the heel at all. I put a ton of padding, proximally put a ton of padding distally. The heel itself is padded, but it's literally physically offloaded. It was just that non-compliance, So sometimes the mental health of a patient, like I said earlier, sometimes that makes a big difference in the prognosis. And it was really unexpected. So I had to get social work involved. I had to send them to physical therapy. I had to get a psych eval, right? Of course, yeah, you're always praying. Absolutely. But yeah, it's, so sometimes those mental health factors play a big, big role. I had another patient who was a domestic violence victim. I did a TN fusion. You look at it, it looks beautiful. It's like textbook perfect. She healed beautifully, no problems. But she always had in the back of her head that it still hurts. I did EMG studies. I sent her to PT. I got a like I did everything possible. I put her in vitamin C. I did topicals. I did like I did all kinds of stuff for her. But because she was so anxious, she'd been in chronic pain for so long, even though it looked beautiful. She would walk, but she'd tell me like, oh my God, like the foot looked beautiful clinically, radiographically. She was able to return her, but she just kept saying, oh, I have so much pain, so those kind of factors make a big difference. All right, stop recording.